So good morning, good afternoon rather. I think almost lunchtime, and hope we can keep this exciting enough that you don't miss the food. I think we have a diverse panel. We have two academicians, both highly recognized, highly celebrated, one on the technology side, one on the business side. We have two doctors, practicing doctors, and so they are the then consumers in some ways or many ways of everything we're discussing in the last yesterday and today. And then we have two from the innovation side. Hitec is from Microsoft. That's working. Microsoft has been doing a lot with a lot of hospitals, trying to do things with data, large amounts of data. And Vivek, who works with startups. So just to get kind of some context for the conversation, I'd ask each of them to give brief opening comments. So we'll first hear from the doctors, primarily around like your experiences with technology and like what's working, what's not working, right? And then we'll move to Vivek and Hitesh to give the view from the whole innovation ecosystem side, and then end with the academic view in terms of where are we really today. So if I can request Dr. Ganesh first.
Yes. So, thank you so much for the opportunity, and really a privilege to be not just amongst the medical colleagues, but also the giants from the most happening sphere in healthcare is AI, and I'm really, thank you, Dr. Chinnababu, for this opportunity. So, the AI in its completeness in India we have a long way to go, but yes, most of the AI we have imported the tools and the models, and we are working India-centric AI tools for our own challenges and epidemiology of our own patients. So last year, Cytuple is a wonderful startup from India. It's now they're doing very good. So in my field, hematology and bone marrow transplant, the single most investigation ordered for anything, any patient, any complaint, the most commonly ordered test is called as something called as complete blood count, right? So, you can just imagine the number of tests being done, and, lack of expertise in analyzing the CBC at various levels has been a challenge. And in that context, Cytuple has come up with a digital peripheral smear and the bone marrow analysis through AI agentic tools, and the impact is so widespread that patients sitting at a very remote village, provided that the lab which is doing these tests has a collaboration with this kind of modern AI service provider. So we see a lot of news that a patient at a remote village being diagnosed with blood cancer at a very nascent stage without any complications, which has subsequently translated into better care and better outcomes. Of course, Government of India is also taking a lot of initiatives in this regard. So there has been more than 160,000. Dr. Nagarjuna has a very insightful talk today morning, that lung nodules, in the similar analogy, the Government of India and public-private partnership. So the cough against tuberculosis, which is a common burning challenge for a country like India, not to the Western world. So all the patients having the symptoms of cough and chest X-ray being done at very remote to the most modern, urban healthcare setups like ours. So, this Cure AI, which is Indian-built AI tool, so screening and early detection of tuberculosis, for which more than 160,000 patients have been screened with simple tools available at the remote areas, and has translated to earlier detection of tuberculosis across the complex mixed cohort of rural as well as urban patients. So, the future looks very exciting, and India is taking its leaps in this arena also. Of course, we are little laid back. We are still importing. Most of our foundational models are Western based, but we are working on our own patient-centric, our own epidemiology-centric solutions, and this is happening both in the corporate sector as well as in the public sector.
No, that's a good context. Now, Dr. Kalyan, can you extend that to what's happening in the onco space, right? Where is technology helping, especially in screening? It's a big problem. I mean, we all know Dr. Chinnababu and what he's doing with Breast Cancer Foundation. It's a big problem, and so how you think is technology helping or not helping with respect to onco cancer screening?
Yeah, good morning, everybody, respected panelists and the audience. Yes, screening is come in a big way. Now we have, as oncologists, we have moved from reactive to proactive management. So it has become a personalized care. So in the proactive thing, identifying the disease very early is the first and foremost important thing, and for that, screening plays a big role. So regarding availability of screening tools, yes, there are many. Quantitatively, they are very good. Qualitatively is the challenge. This is a domain wherein these tools need to be, deployable, scalable, and then they need to be easily integrated into the workflow systems. So we know there are a lot of FDA-approved quality systems outside India, but in the Indian context, where still breast cancer is the most common cause for cancer deaths, and even today, 70,000 patients die of breast cancer per annum. So this is just because they present late, because of inadequate screening facilities. So this is a context where domestic players come in, and this is where a few systems like the Dermalytics, the iBreast exam, and the Mammo Assist, these are things that work with dermography. So for long, radiologists were not in favor of dermography because dermography picks up signals from vascularity in the tumor and it gives you as a visualized signal. But these are less accurate. So with the help of AI augmentation, they are able to pick up these things much better. So in the same manner, we have, for lung cancer as well, low-dose CT scans. But again, like I said, the challenge is real-world validation. That is where the National Cancer Grid has come into play with a program called Cancer AI Technology Challenge, along with SAHI, which is a Government of India project. So they are bridging the gap between the 300 network hospitals, which are private as well as public. So to test these AI models and give real-world backup. So yes, we have good tools, but yet to be validated.
So the challenge is the Indian angle, right? Building from India with Indian data. Yeah, we'll discuss that. I think there's a big problem. We'll discuss, drill down on that a little bit. Vivek, now on the other side of the solutions, right? I mean, there are the startups that are building the solutions. What do you see as their challenges? I mean, why are these solutions not coming fast and frequently enough?
So I think, first of all, thank you. Thank you for inviting me. And I was kind of joking that when I'll sit right in the middle so that when the intellectuals are talking, I can be the full stop and the comma in the middle of all of this. But, having spent a fair bit of time in the startup space and now currently also co-founder of a company in the healthcare space called Anugya Holistic, I think three things, Ramesh, that I see which are a challenge. I think one, to pick from where he left off, is on the validation. How do we define this validation? From the startup world where we come from, 94%, 95% accuracy is good, and we would look at it as a good yardstick. But when it comes to healthcare, the question being asked is that 94% accuracy is okay, but when it leads to a death, whose name is going to go on to that? Is it that 94% accuracy or is it that one death? So I think that's where the validation challenge happens, and I think we have to reframe, redefine what validation means in this space. I think the standard norm probably may not apply here, and I think it needs to be reframed and looked at very differently. The other thing from a startup language, startup narrative that we look at is very different here is who's the buyer, who's the payer, who's the user, who's the customer. And I think in the healthcare space, again, that's a big challenge. So when we are looking at validation, I think the mindset needs to be worked on to be able to differentiate between them more specifically for this space. And I think the last point, which I think is very, very important, and again, I think he alluded to that, is the fact about data availability. Because today, a lot of this work can be scattered. It's fragmented. Some of it is happening in the large institutions, But a lot of that, by nature in startups, is happening in small outfits. And they are the ones who are most under access to the data. And they are struggling because they don't have access to the data. And at some level, there is a protection, partly because of the act which came in recently, but partly because of the undue advantage that the large institutions want to hold, because that gives them the undue advantage of saying, we'll stay ahead of this because we have the most powerful tool available, which is data. So I think till we don't solve these 2 or 3 problems in terms of reframing what is validation, understanding this landscape slightly differently than the other landscape, and looking at data more holistically and how do we make it available to everyone, I think that will stay a little bit of a challenge, and I think till we don't overcome that, we may not see as much success as we would like to see.
I think very relevant, and I don't even know what the solutions are. We've been hearing this for a long time. We did the MedTech Hackathon for BioAsia first time in 2014-15. I think the challenges, it's a deja vu. I mean, 10, 11 years later, it still seems to be the exact same problems and not solved yet. Hitesh, you have the large company view, right? You work with large hospitals and medical chains. Is it easier if a hospital were to do it by themselves? I mean, your thoughts based on your experiences working with large hospitals.
Yeah, first of all, good afternoon, everyone, and really want to thank organizers and everyone who is here attending. I've attended many IT conferences. I can tell you there's lunchtime and you don't see people. And I really want to thank everyone to be present here, be attentive. Regarding the question, I think we discussed that yesterday about multimodal diagnostic and other things, but I think what really enables or accelerates, amplifies the value of all this is going to be the cloud infrastructure. I mean, think about it as a nervous system or a highway that is connecting all the different pockets of data towards something that can be accessed immediately, which is interoperable. Again, it comes with its own challenges, and we are getting there. But from a government perspective, right, the Ayushman Bharat digital mission, as we call it, again, it's not a centralized data. It's more of a fraternity data that we are all going towards. But I think it really is a foundation for building this strong, very, very agile infrastructure in future, where a patient going to an hospital A with all its history may have met with some other untowards emergency in a different city, may get the same historical records where he goes to another hospital. So I think that success of this cloud amplification will depend on how we all, as a hospital fraternity, also align with similar kind of initiatives that government is taking and will be taking. So looking forward to that.
I think
era.
when that happens, and as AVDM projects, if it happens, when it happens, I think that would be utopia almost, right? Today, with patient consent, also there's a lot of struggle to get data, because the data is kept by organizations and it's not meant for sharing or not designed for sharing. So all kinds of procedural and tech issues. Yeah, we'll drill down on that as well. One more thing to, Sir PGN, sir, creating emerging tech solutions, like both the doctors observed, a lot of solutions come from outside the country. Our own data, our own tech, our own scientists, right, and our own engineers is a challenge. So your experience is trying to bridge this gap, sir. Academics, we have a lot of knowledge. I don't think our level of knowledge in these areas is any less than the best in the world. And still, we barely create solutions. Your thoughts on the structures that will help, sir?
Thanks, Ramesh, and thanks, Chinnababu, Dr. Chinnababu, for inviting us here. Yeah, I think one of the fundamental bottlenecks that I see in the Indian system is the technologies, or the people who create the solution, apply technology, and the clinical practitioners and doctors don't work together. And this is a very fundamental problem. It is said that medical education in this country and engineering or science education, if you go up in the hierarchy, the regulatory or oversight hierarchy, they meet only at the Prime Minister. Because the MHRD, the Ministry of Higher Education, doesn't even own the medical education. Okay, so Triple IT got into a small project of neuroanatomy, visualization, etc., spurred by Dr. Valiathan, the famous cardio surgeon who passed away, he said when he came back from the US, he wanted to, he was appalled at the opportunity of, no opportunity of working with science or engineers to create this solution. So he had a job, he got a job in Delhi in some medical establishment. He left that, he went to IIT Madras. He was a faculty at IIT Madras for 1 or 2 years. And he said IIT had even less opportunity to do this because he was the only one who was doing it. Then he went and started Chitra Institute in Kerala, etc. So this structural issue, it's all easy to blame data because it's always somebody else's problem. You can blame somebody. But this is a structural problem. At IIIT for the last 4 or 5 years, we have been trying to do a lot with multiple hospitals and clinicians. So we work with Yashoda, there are several projects going on. With AIG, we are talking to American Cancer Hospital, many. All these places, the one problem is there is no incentive or there is very little incentive for people to work together. And somehow this has been separated from the beginning. Even in this panel, the doctors are sitting at the other end and we are all sitting this side, whether it is symbolic or not.
I'm on this side.
So, this is the fundamental barrier to be broken, that we are together to create some solutions. And, medical, and today, of course, this AI and technology has become so big, and, one of my friends says, AI is a technology that went from the curious, interesting thing to the dangerous without stopping in the useful territory for sufficiently long enough, okay? The medical fraternity has realized that healthcare is too important to be left only to the doctors. The AI people have not realized that yet. The AI things have been developed by AI people, and now suddenly you are finding so many things. And then the sovereignty issue, yesterday the entire Claude, whatever model, was banned for use by non-American citizens, even those working in Claude, the company, I'm sure there are hundreds of Indians working in Claude company developing that. They can't use that themselves. This is the level of potential things that can happen. And in fact, even back close to home and very easy to understand, when neurosurgeons diagnose Indian patients, they still use brain maps from Europe or US, which doesn't fit us. And there was a small effort by one of my colleagues about 10 years ago on creating an Indian brain atlas. She developed it with 100 healthy Indian population, but 100 is not enough. You need to scale it up to some 1,000 or 2,000 and then let it run through the regulatory system so that it reaches the every neurologist or neurosurgeon who are diagnosing. So there are problems, and there are some of them. There is no need to not solve this problem of diagnosing our patients using our data, not somebody else's data. We are harming ourselves. Yet there is not enough incentive to do that. So I see a fundamental difficulty is the wall between these professionals of the clinical professionals and the technology professionals. And that is the one that you should chip away slowly, if not with a big thud.
No, absolutely. And so you try to do the same thing at scale across institutions, Ajit sir. How is that? I know it's almost 10 years since the journey started. I still think it's an extremely unique, I don't think there's any such initiative which is trying to, a non-governmental initiative, not a government ministry doing it. How has that experience been and some learnings, and what would you advise, say, as like institution like Droupadi gets into it in a bigger way, hospital like Yashoda are willing to participate. What are your learnings and suggestions, sir?
So let me just step back a little and then come back into that. As academics, we should focus on solving the core issue. And certainly when it comes to NCDs, NCD is a problem created by us, it's a human created problem. In 2012-13, somewhere in that time, when Raghuram Rajan was the chief economic advisor from ISB, we had given him a white paper that the entire government policy of giving free electricity, free water to farmers, and keeping a high minimum support price for rice means that people are shifting from doing other healthy foods to producing more and more rice. Then the government uses that extra polished rice and gives it at low price to the poor, who instead of then earlier using millets and healthy foods, is now eating large quantities of polished white rice only. And then we surprised that there is diabetes, there is blood pressure. It's a human created problem. And academic institutions have a duty together with doctors to really start pushing this issue that this is. Now we recognize that it's a political problem and it's not easy, this is the question of votes. So what else can we do? And what we have done is we have worked with the agriculture institutions. So we said, if anyway this is going to happen, can we at least fortify the rice? Can we ensure that the rice has more nutrients? So one of the things that we were able to come out was a low glycemic index rice. So academic institutions have to find newer solutions which are different so that they meet the requirement. And in some of those we have had some success. It's taking time. Obviously, new rice and then the government bureaucracy, we created the low glycemic index rice and then they said only the central agency can give the same. So what happened was the seeds were illegally taken by people and so that happens in India. But that is the second thing that we have to do. The third thing that we realized when we started this was, as you rightly said, the complete lack of incentives for each member to collaborate. Right? Firstly, if you look at the US, in terms of hospital data management, there are just 2 or 3 really big software companies which do most of it. Here, every small software company is doing the software for each hospital. So there is a wide variety of this thing. There is no data standardization. If I suffer from something, is it called what? Each hospital and each one has that. So and then what is the incentive for me as a private hospital which has put in a whole lot of money to actually share that with somebody? So we've now been working with the Akhil Bharati Mission and says, look, you better find something. So one of the incentives that we think is likely to work is if with that we automate the insurance process so that immediately the hospital gets payment. And so there has to be, so I think academic institutions, and one of the jobs that we've been trying to do, honestly unsuccessfully so far, is to find those standards and find ways for everyone to collaborate together so that we can have access. Now, then comes the privacy law, which we heard about. Now, it's not, nobody wants to know whether it's Ajit's or PJN's or Vivek's data, right? We just want to know what are the basic primary statistics with that. So for now it's 7 years, we were trying to get genetic information, gut bacteria information, and food habit information, and start then this was done with National Institute of Nutrition, CCMB, etc. We created the project, no funding. So our problems are that I think as a community and as people, we know a lot more that we can do. Somehow or the other, the one thing that is missing is funding. And the other thing that is missing is therefore, for the funding, the right incentivization process. So a lot of work nowadays is on that.
Of course, funding is a big problem, but data is the other problem as well, especially when it comes to medical.
There is no data because there is no incentive for me to share
yeah,
data.
It's a vicious loop. It's a vicious loop. Now with ABDM and others coming, of course, it's left to be seen, given it's a concurrent subject, when will the actual adoption happen at scale, and large hospitals are not incentivized to adopt that until there's a regulatory mandate.
There will be a regulatory mandate soon. I'm absolutely sure that in this 1 year or so. So there has been, and I'm sure many of you know J. Satyanarayana. So JS was in fact, I think JS was the chair of the group, which has a few months ago submitted a report to the government on what should be the incentivization to make this happen. I'm not privy to the report. Even if I was, I wouldn't talk about it. Yeah. But I genuinely am not. But I think it will come very soon. Obviously the elections were the first priority of the government. They are out of the way. Now this war and petrol prices are the next thing. But very, very soon, ABDM will come. As it is with any government incentive, it will be imperfect. it will have its own. So we will have to then go through a series of
Iterate.
things. But I think it is right, and the important thing is that the government has accepted that their first initiative was a failure.
Good start, very good start. So Dr. Ganesh and Dr. Kalyan, do you think the hospital systems are ready for something like ABDM? Say if you have to standardize, today small innovations happen because we come work with a hospital or a doctor, we get like Pigeon said, with just 100 samples we create an Indian brain atlas. We are a 1.5 billion population country. 100 samples to create an Indian race ethnic brain atlas. So some small innovations happen in pockets where there's a very kind of enthusiastic doctor and work with the system. To do it at scale, standardization is key. How is it today? I mean, are the information across like just even disease conditions or different conditions, are they standardized in some way that we are ready for ABDM if we were to adopt?
Pointed out by sir that the data across the problem is not the data. Data is enormous. India is healthcare. With regard to healthcare, we have ocean of data, but the majority of data is not filtered, it's shattered, and every hospital, as sir has said, is a it's independent island of data. That's a lot of noise because it is not annotated by a specialist. Right. So of course we are taking steps to get clinicians involved in annotating data, refining data. It's going to take time, but yes, it is happening, and we are at a very nascent state. Probably over, we have just taken our baby steps in this arena. I'll just quote an example. At Yashoda Hospitals, we have collaborated with a couple of US universities. When the Human Genome Project was launched in 2006, the entire head-to-toe, one-person genome, the cost was $600 million and the turnaround time was 9 months. Today, the cost is just $100, $200 and the turnaround is 6 hours, right? So, and majority of the labs in corporate hospitals like Yashoda, commercial labs, are doing NGS, the genomic analysis, whole genome analysis, left and right at a very peanut price compared to Westerners. So we'll have a lot of data, right? And that's where, as a clinician, we are very optimistic that, as sir has highlighted, the collaboration with the tech, colleagues and refining the data. Maybe I'm so optimistic that maybe, 3-5 years down the line, majority of the hospitals will have entire person genome, just like a barcode scanner. We can tell what are the diseases in evolution now, diseases are happening after 5 years, 10 years. That's the kind of knowledge base, database we are going to develop. And as correctly, highlighted and elaborated by my eminent techno colleagues, it's the high time to collaborate and, get this thing happening, because we have our own challenges. We have our patient set. The entire cohort is totally different. It cannot, the data from the Westerners with regard to healthcare cannot be, exactly applied to the Indians. I just share some examples. A simple tool, I will say, deadly blood cancer like AML. The standard of care across the globe is intensive chemotherapy. But if you go into the nuances of the intensive chemotherapy, because of the rampant resistant infections in our subset, the mortality in first month is 20 to 25%, where in the Western world it is less than 3%. So how can that data or that standard of care apply to a patients in India, right? So there are various other tools which we have to develop our own, and then in that regard, I think this data refinement, there's a lot of data, is a lot of noise, and that's where our initial grudge and negativity comes from. So if we collaborate and start getting this data refined, more than half of the data in Indian healthcare is not even digitalized, right?
So there is I have I think a quick win possibility. We've tried it. Again, I've got a whole list of things that I've tried and have failed. So I've got a big thing on failure. Public hospitals. Public hospitals are not digitized at all. So there is no worry about taking old data and correcting it and this thing. There is enormous potential also all things said and done, at the private hospital, a certain kind of patient comes, a certain kind of population does not come. The vast majority of, therefore, we are likely to escape a large number. We will not likely to get a representative sample of the country. So I think if some of the tech companies, the top tech companies, offer to the government that we will digitize this as a common good, start from there, start with the standardizations, I think we'll get more than enough. And the kind of data that they deal with, right? NIMS deals with some 3,500 every day. I mean, just 3, 4, 5, 10 hospitals will give you all the data that you need. It's a question of how do we...
And with the sufficient diversity. Yeah, Hitesh, I'll come to you, Kalyan.
So I just want to add, so excellent idea, and I think that's where it's a big opportunity because it's a clean slate. We can build on it quite quickly, and we'll take that into consideration. We'll discuss that further. I think on ABDM too, I wanted to add something. In terms of execution, I know it has its own challenges, it had resistance and all that, but from an architecture perspective, I think it was really well thought. I think we need to commend the Indian government.
True.
When they come up with such large designs, they come up with an architecture which is for all. So it's not designed on a Microsoft stack or a Google stack, or it is designed independently by GUI, and it is designed such that anyone, so if you want to do, it's all API based, similar to what our UPI started with. It's very similar architecture. So logging on to that technically is not difficult for any hospital on technology A, B, C, from small stack, large stack, they can all join into that. It's the execution part which I guess will...
I hope it happens soonly. Dr. Kalyan, you're going to add something to it.
In continuation to Sir's discussion about this Cancer Genomic Atlas and the data collection. So now we have a National Cancer Tumor Biobank that has come up in collaboration with IIT Chennai. And they collect fresh tumor samples from cancer patients along with the clinical data, and they process. They have a store there. And this is fueling the project something called Bharat Cancer Genomic Atlas.
So the same as the NCG?
Yeah. So this actually had produced a paper that showed that 1 in 4 breast cancer patients have a different inherited genetic risk, and these are way different from the BRCA1 and BRCA2, which we see quite often in the Western population. So as you said, India itself is a heterogeneous population, and we are genetically and phenotypically different. So applying Western data is not the thing at this point.
So Vivek, I'll just come to you. Before that, Pijan sir, on that point, I know there are these tiny silos. I'm sure it says national, but it's probably like from some narrow set of source hospitals and happening probably just in IIT Madras. Not that nobody wants to collaborate. There are extremely collaborative academicians. Just that the system and support and everything, so it just doesn't happen. How do you make this happen? I mean, if unless multiple institutions collaborate with data coming from multiple organizations, we can't get the scale needed, like the example Dr. Kalyan just gave. It will become very narrow observations. How do we make that happen, sir?
Yeah, this is a hard question, and Ajit already said it's very hard to get these people to work together. I mean, yes, standardization of data or availability of data, these are required to do anything at all. But that alone is not enough. And individually, what has happened in the Indian academic system is individually, all the individual academics are very friendly with each other, very, they work on committees, etc. But they rarely work together on projects. And there is funding issues, certainly. But in general, there is, the government of India tried many of these, the hubs that created by the ICPS was supposed to be collaborative, made collaborative, but I think there's insufficient experience in the country, and that has to be incentivized by the funding agencies. Or I think funding agency is one thing, but even there's a lot of CSR money or a lot of private entities who have run these things. If you look at Microsoft or big companies, Tata's, they have been part of several projects over the years. I think they can do this more effectively because they will be quicker to respond. And then government can join. Anyway, government is asking these days, for every rupee they give, they expect 3 or 4 or 5 rupees to come from private sector, etc. So the catalyst role that companies can play to set up the model, right model, Funding itself probably not so short in the government. It's just getting it the right way is the problem. So
no, absolutely, I think something radical must happen. So Vivek, last word, we already finished the time, but last word when you represent, at some level all of these converge, right, at startups, right? That's where the innovation can happen, but all of these are required for that to happen. So,
so I think,
final thoughts.
Yeah, my final thought would be just taking on from where PGN left. I think, the point he made earlier that the convergence today happens only at the Prime Minister's level. And I think that, in my view, is the biggest problem that we are facing today. That this problem, the large private players, is more a private margin game, that how do I become better than the rest of the world. And in the government sector, it has become a CSR game. And somewhere we are missing the fact that these need to get integrated somewhere. And I think till we don't look at it as an ecosystem play, that this is a combination of what happens in private play, what happens in government, what happens with the government funding. Funding, I don't think, is a challenge at all. If we are able to present that coherent picture, that this is how the nation is going to benefit, and as a result, each one is going to benefit. There is enough on the plate for everyone to take away, but there is enough for us to give. I think the bigger challenge today is that all of us wants to take away, but very few of us are wanting to give back. And I think that's where the future, in my view, lies. And I think this problem is solvable, like many others the startup have solved. But we need to get together, we need to come together, and I think somebody needs to play that role. Should it be the government, should it be the private healthcare players, or should it be the technology players? I think we need to figure out who, but somewhere somebody needs to take that lead.
In that very insightful analysis lies the solution.
Yes.
You said money is not the issue. And PGN sir said, like, if there's money, we can fix it. And Rajesh sir is the catalyst. You get the money, I'll take care of the rest. So on that note, I mean, always there is things to look forward to optimistically, right? So I'm sure things will be much better in the coming years. Thank you so much. Wonderful insights. Thank you so much. And thanks to Dr. Chinna and Yashoda for making this happen. Thank you.